Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaj. Pediatrics, very scoring subject. 10 questions are going to come and very easy to master, unlike general medicine. Pediatrics, orthopedics, CNT, ophthalmology, these are all 100 out of 100 you can score and come out of the exam hall. If you know what are the common questions asked by the examiner, what are the high yield facts that you need to master? If you take pediatrics, there are around 1500 points in about 35 pages notes I have given to all of you. I consolidated the entire pediatrics to the point for the last moment revision. So today only order for the 1200 pages notes. It will be there at your home. We will courier you and you master the subject briskly and do as much revision as you can. So let's make the great beginning, doctor. Can the online students can punch? Is the voice loud and clear for all of you? Can you please punch, doctor? Now, a 3-month-old girl presents with apnea. She has been well that morning, but crying inconsolably, more mottled, and she was born 3.6 kg, and at 40th week, heart rate is 240, pulse is steady. She has 3 centimeter liver. Gallop rhythm is a very important clue to say that the patient is having apnea precipitated by tachyarrhythmias, which is typically a supraventricular tachyarrhythmia. So how do you recognize, doctor? Nice to see Ibiavuchi Patrick Nudike after a long time from Portugal, Kuldeep, Manikandan, and many more who are all online. So today had been a very hectic day. We conducted a health mela with around 150 patients. But after reaching home, I thought, at least let me discuss some questions every day so that you are motivated for the exam. So I hope you all took this question paper. This is Pediatrics question paper 1, actually yesterday's paper, right? So we have a online web engine in which we have the everyday 100 MCQ question paper is being uploaded, right, doctor? Now, any narrow complex tachycardia is considered to be SVT, whereas broad complex tachycardia is considered to be ventricular tachycardia. Unless proven otherwise, any broad complex tachycardia is ventricular, narrow complex tachycardia is supraventricular. And how do you treat it, doctor? Supraventricular tachycardia is treated with adenosine and give digoxin for maintenance therapy to slow the ventricular rate. So that is what you need to do. You need to do an echo to know the underlying structural defect. Which kind of a murmur is an innocent murmur in a 4.5-year-old child? Very important. Innocent murmurs are of short duration, vary with posture, whereas if there is a thrill, it means to say it is no more innocent. There is a valvular heart disease. It means there is a valvular heart disease because thrill is an indication of turbulence, and presence of turbulence is not the nature of an innocent murmur. Any radiation to the axilla means mitral regurgitation. Any fixed splitting means atrial septal defect. That's what you need to remember. Cyanosis is a typical feature, doctor. So inform all your friends that the live class has started. Yes. So, cyanosis is a typical feature of which condition? So you should remember 4 T's associated with cyanotic heart disease. T for tetralogy of Fallot, T for total anomalous pulmonary venous circulation, T for tricuspid atresia, and T for transposition of the great arteries. The 4 T's that lead to cyanotic heart disease, you should not forget. Whereas ASD, VSD, PDA, they are all called cyanotic until the shunt is left to right. It is all cyanotic. The moment the shunt is from right to left, then the bad blood goes and mixes with good blood, and that lead to development of cyanosis is what you need to remember, doctor. Now, a 4-year-old child with classical murmur of PDA, underweight for age, what do you recommend, doctor? So, whenever early operative closure, whenever the defect has persisted beyond 6 months of age, 4 years child it is, beyond 6 months, early operative closure is considered to be the treatment of choice. 9-year-old boy presents with fever and joint pains. Initially, the pain affected his right wrist, but now affects his left wrist and right ankle. So, sore throat, fever, migratory polyarthritis, heart murmur, they all are suggestive of acute rheumatic fever. So, what do you have in acute rheumatic fever? Fever, arthralgia, raised acute phase reactants along with prolonged PR interval is a very classical feature. 2-week-old girl presents with history of poor feeding. So, shock, hepatomegaly, and hypoxia in a 2-week-old child. The gist of the entire clinical vignette, if you read, shock, hepatomegaly, and hypoxia, 2-week-old child. So, it is a duct-dependent congenital heart disease. Aortic coarctation, truncus arteriosus, critical aortic stenosis, hypoplastic left heart syndrome, they are all the left heart lesions which present like this because they are all duct-dependent congenital heart diseases. Similarly, transposition of great vessels, severe Fallot, pulmonary atresia with or without VSD, they also present with shock, hepatomegaly, and hypoxia is what you need to remember. So congenital heart disease is broadly divided into duct-dependent, duct-independent. We discussed all this in great detail in our regular video lectures in core learning app. So today only take every opportunity to do the revision, doctor. Now, congenital heart disease, typically Down syndrome, endocardial cushion defect, whenever it is there, that lead to irreversible pulmonary hypertension. What are endocardial cushion defects? VSD, ASD, and all this. They are all left to right shunt. So the right-sided blood flow will increase. That lead to pulmonary hypertension. But that pulmonary hypertension development in a endocardial cushion defect is more common whenever that endocardial cushion defect is because of the Down syndrome is what you need to remember. Coming to atrioventricular septal defect. Those who are having Downs, trisomy 21, they have atrioventricular septal defect is what you need to remember. So I leave all this literature in the explanatory answers which are there in our online test. But still, if we both discuss few questions together, then it looks very interesting. You feel motivated to prepare every day for the exam. That is the whole purpose, doctor. A 2-year-old child has an uncomplicated coarctation. The constriction is located distal to the left subclavian artery. So, in this case, what will happen? So, what is meant by coarctation of aorta, doctor? It is a narrowing of the aorta. So, where is the narrowing? it is distal to the origin of the left subclavian artery. So that means left subclavian artery is receiving good blood flow. So upper limb pressures are good. Lower limb pressures are lower limb, the blood flow is diminished. So whenever coarctation is there, there are two types of coarctation. One is called compensated coarctation, uncompensated coarctation. Whenever fully compensated coarctation is there, the blood flow is normal in both the upper and also the lower limbs. Only thing is the upper limb will have a higher pressure compared to lower body. So how is it possible? If you look at resistance, resistance is equal to pressure divided by blood flow. So blood flow, typically if you see, it is same. Denominator is same in both. But the pressure, if you take, it is higher in upper limb. That is only possible because of higher resistance in upper limb and lower resistance in the lower limb. In a compensated coarctation is what you need to remember, doctor. A 40-month-old baby is brought dead to the hospital. So this is a typical presentation of SIDS. Sudden infant death under the 1 year of age, there are certain predisposing factors. Maternal smoking, prematurity, overwrapping of the baby, intercurrent infection, prone sleeping position, low socioeconomic states, they all lead to syndrome of sudden infant death syndrome is what you need to emphatically remember for the tomorrow's exam. Can you please punch, Doctor? Kuldeep, Manikandan, everybody. Is the voice loud and clear for all of you? Can you please kindly punch? 18-year-old man has repeated episodes of breathlessness and palpitation. They are lasting about 20 minutes, resolving gradually. What is the cause? It is the panic disorder. Panic disorder. So, in this case, drug abuse is unlikely because her symptoms are quite short-lived, only 20 minutes. And paroxysmal SVT, if it should start and stop suddenly, not gradually. And personality disorder or thyrotoxicosis, it cannot be because both of them will lead to symptoms of longer duration is what you need to remember. Thank you, Kuldeep, Jabjot Singh, and everybody who are all online for the feedback that the voice is loud and clear. A child aged 10 days has ambiguous genitalia. So ambiguous genitalia, congenital adrenal hyperplasia is very common cause. Any raised urinary output of pregnant triol is a confirmation of the diagnosis. So the commonest cause of ambiguous genitalia at birth is CAH. Most common enzyme which is defective in congenital adrenal hyperplasia is 21-alpha hydroxylase deficiency is what you should remember. Good. Good to see a stable 11 online classmates. So you should know different glucocorticoids. We consider hydrocortisone equal to 1. Prednisolone is 4 times powerful than hydrocortisone, potent. So 20 mg of hydrocortisone is equal to 5 mg of the prednisolone is what you should remember. And dexamethasone, dexa means 10 times. It is 10 times powerful than the hydrocortisone. So you should know the relative potency. In fact, dexamethasone is 30 times more potent than hydrocortisone is what you should remember. A 15-year-old girl with agitation, weight gain, and her T3, T4 values are all given. TSH value is also given. So what is this story? She has normal thyroid function tests reflected by free T4, T3, normal TSH. But her total T4 and her total T3 is elevated. So that is because of the elevated thyroid hormone binding, which is typically a feature of pregnancy, is what you should remember. One of the favorite questions in the exam. So what is Pendred syndrome, Doctor? Hypothyroidism, goiter and deafness is called Pendred syndrome. 16-year-old female, primary amenorrhea, 46XY karyotype. So what is your diagnosis? So XY karyotype, female in phenotype, XY in genotype is testicular feminization syndrome. In a boy of 7 operated for craniopharyngioma. So typically that lead to poor growth, because after craniopharyngioma is removed, panhypopituitarism can occur, because of which growth hormone deficiency leading to short stature can occur. Very nice to see Babu Guduri and many more who are all online. Thyroid hormone receptor fundamentally is a nuclear receptor. Now, poorly controlled hypothyroidism in a 18-month-old infant. Poorly controlled. You expect constipation. Why do you expect diarrhea? No. Umbilical hernia, delayed bone age, high plasma TSH concentration, they're all seen. A 2-week-old male, obvious dehydration, penile length is 3.5 centimeters. So you should consider the possibility of salt-losing crisis with a penile overgrowth, that is male virilization with ambiguous genitalia. So that all confirms the diagnosis of 21-alpha hydroxylase deficiency is what you need to remember. 16-year-old female presents with hypertension, increasing weight. So what is suggestive of Cushing syndrome instead of simple obesity? So you should remember, abdominal striae, acanthosis, buffalo hum, they're all seen in obesity. But proximal myopathy due to excessive steroids, steroid-induced myopathy, is a feature only in Cushing's but not in simple obesity. Antidiuretic hormone. You should know what are the reasons for drugs leading to SIADH. What are the drugs leading to diabetes insipidus? You should know the differences. Ethanol inhibits release of ADH. That's the reason when you drink beer, whiskey, etc., you feel like running to washroom, because ethanol inhibits ADH. And if there is no ADH, what will you have? Diuresis. That's the reason our bladder is full and we run to washroom when we drink. So carbamazepine, thiazides, SSRIs, they all potentiate the release of the ADH is what you need to remember. So you need to have that list, very important. So all the preparation for NEET PG exam is list, facts, few reasoning points. Totally 50,000 whole database. If you are able to master, you are the winner. There is 1,200 pages notes, which I will send you by courier when you subscribe to us. And that's all will help you to become the winner. 14-day-old boy, 14-day-old boy, sodium is low, potassium is high. So it is a case of shock. Patient is progressively dehydrated. Sepsis, congenital heart disease, they are possible, but nothing is pointing in that direction. So salt-losing congenital adrenal hyperplasia, whenever you don't have aldosterone retains sodium, loses potassium. If it is not there, potassium is increased, sodium is decreased, is what you need to remember. 11-year-old girl, thirsty, drinking a lot of high glucose. Mother has thyroid disease. She's sighing the breathing. So she has a cool periphery. She is dehydrated. That is a classical story of diabetic ketoacidosis is what you need to remember. Jabjot Singh is asking, sir, what we have to pay for notes? So please call Manu. Please call or text Manu. He will help you, doctor. So I will give you Manu's number 9704927613. Okay, so please call Manu. He will help you. 9704927613. You can WhatsApp or call Manu. He will help you to get the notes, 1200 pages notes couriered to your home. Now, type 1 diabetes, usually the onset is very acute. And in type 2 diabetes, already it started 5 years ago. That's the reason there is a chance of finding retinopathy. Whereas type 1 diabetes in children will take at least 5 years before retinopathy doesn't appear. Now, with regard to the precocious puberty, so with regard to the precocious puberty, it is often associated with hydrocephalus. Hydrocephalus will interfere with the release of the luteinizing hormone, releasing hormone. That's the reason precocious puberty can occur. It is 5 times more common in females, usually idiopathic, but in the case of the males, it is hypothalamic hematoma which can cause even hydrocephalus, cerebral palsy, trauma, meningitis. Anything can lead to development of precocious puberty. Now, 7-year-old girl presents with crampy lower abdominal pain, loose stools, anorexia for 3 days. She has few purpuric spots on her legs. So what is the most likely possibility? So you should remember, dysenteric illness followed by hemolysis, followed by renal failure, along with renal failure. And presence of fragmented RBCs, schistocytes, spherocytes, helmet cells, polychromasia, everything is in favor of hemolytic uremic syndrome. A neonate does not pass meconium. There's a massive dilatation of colon. So what is this, doctor? Hirschsprung's disease. It is a neural crest disorder. Is the Hirschsprung's disease is what you need to remember. A 2-month-old is referred with abdominal mass, low set tears, frontal bossing, depressed nasal bridge, long philtrum, 4 centimeter hepatomegaly, 3 centimeters splenomegaly, poor head control. So consanguinity, dysmorphic features, hepatosplenomegaly, developmental arrest, they all suggest a storage disorder like infantile GM1 gangliosidosis. 50% of them will also have a cherry red spot. One of the favorite questions of the examiner doctor. So, infant with gastroenteritis. Gastroenteritis. Now, with regard to gastroenteritis, it is one of the indication to admit in hospital if they are unable to tolerate the fluids orally. Lactose intolerance. It is one of the important cause for gastroenteritis. Cystic fibrosis with abdominal pain. What is the cause? In cystic fibrosis, all the meconium secretion become thick and viscid, leading to meconium ileus, which is responsible for abdominal pain and intestinal obstruction. With regard to untreated celiac disease, so they have a subtotal total villus atrophy, anorexia, weight loss. For them, gluten-free diet is required lifelong, is what you need to remember. And very important thing about the celiac disease, abdominal distension also can be there, but not necessarily always. Acute hepatitis B, presence of envelope antigen is a marker of infectivity, is what you should remember. Most of the hepatitis B patients are asymptomatic, but they can end up in acute fulminant hepatitis, chronic hepatitis, membranous glomerulonephritis is what you should remember as complications. 17-year-old male brought by the friends at a nightclub after drinking 8 pints of beer. He felt nauseated, vomiting, and duodenoscopy is normal. So, how do you want to manage? So, all this drinking, retching, vomiting with a bright red streak, such as malarivis, generally it is self-limiting, no additional treatment or follow-up is really required. Now, a male child weighing 4.2 kilos, he is alert, eager for food, but exhibit loss of the skin elasticity. There is an apparent distension in the left hypochondrium. So, left hypochondrium, that means hypertrophic pyloric stenosis. More common in males, presents between 3 to 6 weeks. And what do you get? Hypokalemic, hypochloremic, metabolic alkalosis is what you get in case of congenital hypertrophic pyloric stenosis, doctor. In Gilbert syndrome, typically serum bilirubin will come normal whenever you give liver enzyme inducers. Gilbert is autosomal dominant, 2 to 5% of population, every second or fifth guy. Isolated hyperbilirubinemia means increased bilirubin with normal SGOT, SGPT, alkaline phosphatase, SGOT, SGPT, everything normal. Normal transaminases, isolated hyperbilirubinemia. In any of the LFT reports, you should think of Gilbert, is what you should remember. Now, a baby of 2 months who is considered to be 10% clinically dehydrated with gastroenteritis. So you should remember, he may have blood and mucus in his stools. So dysentery with E. coli infection, you can see blood and mucus, fontanelle are sunken, hematocrit is raised. False positive sweat test, where do you get? Glucose 6 phosphatase deficiency. There are many causes, non-cystic fibrosis conditions where the sweat can be having an elevated sodium chloride. That include endocrine causes, metabolic causes. So you need to be very sure what are the various causes leading to elevated sweat chloride levels. 17-year-old male attends clinic, complaints of right hip pain, left ankle pain. They all deteriorated with episodic diarrhea. What is the cause? Classical of ulcerative colitis. Oligoarthropathy plus episodic diarrhea. You should remember, doctor, what is the cause? So whenever oligoarthropathy, so whenever there is any oligoarthropathy with episodic diarrhea, think of inflammatory bowel disease. A 5-year-old girl has isolated anemia, dark stools, abdominal pain, that all suggest a occult source of bleeding from upper GI. So it can be esophagitis, peptic ulcer, Meckel's diverticulum, NSAIDs. So anything is possible. So occult blood loss should be suspected. A 7-month-old baby with severe vomiting and diarrhea. So in summary, acute gastroenteritis is there. So it can be viral, most likely rotavirus in winter, Norwalk, adenovirus, astrovirus, calcivirus, anything can cause. Manage the dehydration, provide oral rehydration therapy is considered to be the treatment of choice. 7-year-old presents with Pelor, 2.89 kg, MCV 69, hinge bodies are found, and precipitated hemoglobin on supravital staining, so that all mild pallor, microcytosis, unresponsive to iron, that all suggests a hemoglobinopathy. You should think of thalassemia. With regard to immunoglobulin E, whenever there is any atopic individual, there is an increased immunoglobulin E. So what is the feature that indicate a poor prognosis? So whenever there are night sweats in Hodgkin's disease, fever, night sweats, weight loss, mass more than 10 centimeters, they are all called B symptoms. Presence of them is indicative of poor prognosis. 17-year-old male, G6PD deficiency, tiredness, jaundice. So what is the most likely possibility? G6PD deficiency lead to acute intravascular hemolysis whenever they are exposed to drugs. Intravascular hemolysis lead to hemoglobinuria. So all differences between intravascular, extravascular you should know. In extravascular you get splenomegaly, not in intravascular. So all the differences you should know. On examination, patient has jaundice in sclera. Temperature is 36.6, respiratory rate 25, 3 centimeter spleen. So mild anemia due to hemolysis along with icterus and splenomegaly, they're all suggestive of hereditary spherocytosis. They'll have a massive spleen at birth, hereditary spherocytosis. 18-year-old has gingival hypertrophy. Phenytoin is known to cause gingival hypertrophy. A 3-year-old girl has pallor, lethargy, bruising. She is on the 25th percentile of the height and weight. No dysmorphic features. So what is the likely cause? Bone marrow failure of subacute onset with at least 2 cell lines, red cells and platelets. So in this case, if there is hepatosplenomegaly or lymphadenopathy, then it is leukemia. But no hepatosplenomegaly or no lymphadenopathy, but pancytopenia, think about aplastic anemia. Any hepatosplenomegaly or organomegaly or lymphadenopathy is against the diagnosis of aplastic anemia, is what you have to basically remember. 16-month-old boy is referred because of the reduced exercise tolerance. Reduced exercise tolerance. He has never been cynosed. 2/6 ejection systolic murmur at left sternal edge. Spleen is palpable. So mild hemolytic anemia, and it is suggestive of sickle cell disease. You can confirm with hemoglobin electrophoresis. What are all the complications of sickle cell disease, doctor? Sequestration, crisis, infections with encapsulated organisms like pneumococcus, painful crisis, stroke, cholecystitis, vascular necrosis of femoral head, priapism. They're all the things that are suggested. A 3-year-old boy, he looks pale and lethargic, petechiae, ecchymosis on the chest and liver is palpable. Any rapid progression of bone marrow failure with features of pancytopenia. The most important thing you need to remember is acute leukemia. You need to do bone marrow biopsy. A 2-year-old boy, rapidly increasing unconjugated jaundice. Pregnancy was uncomplicated. Polychromasia, nucleated RBCs. Direct Coombs test is negative. So, what is the most likely possibility? Severe unconjugated hyperbilirubinemia without evidence of isoimmunization means it is red cell membrane or enzyme defect, like hereditary spherocytosis or pyruvate kinase deficiency. Hereditary spherocytosis, pyruvate kinase deficiency, they are all Coombs negative hemolytic anemias, is what you need to remember. So, doctor, with this we come to the end of the today's evening. Rose milenge, rose padenge. There is a schedule of 100 subject-wise tests, Monday to Saturday, and on Sunday, full-scale grand test. Take every opportunity to revise with me. But solve the question paper first. Every day, you are taking 100 questions, solving them, discussing with Dr. Murli. In 100 days, you finish 100 into 100, 10,000 essential questions. And 20 grand tests, 20 into 200, you will finish around 4,000 questions. ये पूरा 14,000 क्वेश्चंस जो 120 डेज में खत्म हो जाएगा डॉक्टर मुरली भारद्वाज के साथ, उसी में से उसी कॉन्सेप्ट्स के बेसिस पे you will get 200 questions in the tomorrow's exam. So to be motivated in life is everything about driving the life until 100, doctor. So good luck and study well.